1 of this year. I welcome Dr. Nas Jahan Sheikh, Chairman KSCASI, to today's program, and I request her to conduct the program. Madam, please.
Yeah. Thank you, Dr. Sarvesh. Good evening, everyone. Respected dignitaries of KSCASI, immediate past President Dr. Raj Gopal Shenoy in his absence, Dr. G. Siddesh, past President of ASI, in his absence again. I think Dr. Rajshekar Jaka, he'll be joining soon. All the executive committee members, and welcome you all to this fifth KSCASI PG time. And I welcome all the members of KSCASI also, esteemed members of KSCASI. And we have two prominent teachers today as examiners, Dr. Manjunath Kotennavar, HOD of Surgery, BLDE Medical College, and Dr. Suresh Badiger, Professor and HOD, SDM Medical College, Dharwad. And Dr. Anandravi and Dr. Sangamesh are the moderators for today. And we have two postgraduates, Dr. Mohammed Shadab Shariff of SDM, who will be presenting on mass per abdomen, and Dr. Gazal Gautam, who will be presenting on right lower limb vascular disease. And I wish you both all the very best, and we'll proceed with the program. Over to Dr. Sarvesh.
Yeah, thank you, madam. Now, without wasting the time, I'll ask request the moderators, Dr. Anandravi and Dr. Sangamesh, to conduct the program. Please, sir. And we have two examiners. The moderators also will be the examiners, I think, will be better. Yeah, please.
Yeah, and Dr. Suresh Badiger has to leave in between, it seems. He has got a train. So meanwhile, I've asked our vascular surgeon, Dr. Sunil Joshi, also to pitch in and be one of the examiners soon for the vascular, especially for the second case. Yeah.
Sure. Thank you.
Yeah.
Good evening, all respected members. Now I request Dr. Mohammed Nazaf Sharif to present his case, and Dr. Manjunath Kotennavar and Dr. Suresh Badiger, sir, to examine. Dr. Mohammed Nadab Sharif, please present your case.
Good evening, everybody. My name is Dr. Mohammed Shadab Sharif. I'm a General Surgery PG from SDM Medical College. Today, I'm going to be presenting a case of a 49-year-old male patient who presented with complaints of altered bowel habits since 6 months, complaints of pain abdomen since 3 months, complaints of loss of appetite since 3 months. A patient presented with complaints of altered bowel habits in the form of increased frequency of stools. Previously, he used to pass stools 1 to 2 times per day, and now passes 3 to 4 times per day watery stools associated with the mucus. He complains of pain in the right lower quadrant of the abdomen since 3 months, which was insidious in onset, gradually progressive, colicky type, which relieves spontaneously. Initially, the patient had pain 2 to 3 times per week, lasting for 5 to 10 minutes. Over the past 15 days, the patient tells increased in frequency of the pain 2 to 3 times per day, lasting for 5 to 10 minutes. And the pain also aggravates after consumption of heavy meals. He gives no history of vomiting, constipation, or abdominal distension. He gives history of easy fatigability since 6 months, history of loss of appetite since 3 months, and no history of and he also gives history of unintentional loss of weight, which was noticed by loosening of clothes and which was not quantified. He gives no history of fever. There's no history of hematemesis or melena or blood in stools. There's no history of passing hard stools or difficulty in passing stools. There's no past history of jaundice, no urinary complaints. There's no history of chest pain or breathlessness. There's no history of lower back pain. He gives history of bleeding PR 6 years back. for which he was evaluated at an outside hospital and underwent surgery followed by chemotherapy for 6 months, following which he underwent a check colonoscopy, during which he was said to have a growth in the colon and was advised for surgery. Then the patient was lost to follow up and took alternative medicine for a duration of 5.5 years. Past history is not a known
Dr.
case of
Shadab,
diabetes. Yes.
may I interrupt you, Dr. Shadab?
Yes.
Can you conclude after history of presenting illness? You have presented chief complaint and history of presenting illness. Can you conclude anything?
So here's a 49-year-old male who presented with complaints of pain abdomen, complaints of altered bowel habits in 6 months, and pain abdomen since 3 months with
Yeah.
reduced appetite. With a history of colorectal malignancy, status post surgery and chemotherapy.
Yeah.
Followed by which,
He was told that he had some type of malignancy, isn't it?
yes, sir.
And he also given you history of undergoing chemotherapy.
Yes, sir.
So what do you think he was suffering from?
He was suffering from colorectal malignancies.
It's probably which side?
Left side, sir. He complains of bleeding PR.
So probably on the
Left side.
left side of the colon, maybe descending colon or sigmoid colon, isn't it?
Yes, sir.
Can you conclude anything extra apart from this?
After the 6 months of the therapy, he was during the follow-up. He was said to have a lesion in the colon,
Yeah,
sir.
but we have not yet discussed much. We have just you have presented chief complaint and history of presenting illness, isn't it?
Yes, sir.
In that history of presenting illness itself, he has contributed the important past history, isn't it?
Yes, sir. Yes, sir.
So what did you conclude by this? Probably he had CA of the colon.
Yes, sir.
Probably they have not done any colostomy. Am I right?
Yes, sir. They are not done colostomies.
Probably they have not done colostomy. Was it an emergency surgery or elective surgery?
No, sir. Elective, sir.
It was an elective surgery,
Yes, sir.
isn't it? That means definitely it rules out lower GI means like CA rectum, isn't it?
Yes, sir.
So he had this job bleeding per rectum. It rules out CA rectum because most of the time in CA rectum, what they do, either APR or anti-resection, isn't it?
Yes, sir.
Even if they do anti-resection, it has to be covered by a colostomy, defunctional colostomy.
Yes.
And probably it may be a higher up, maybe
Yes.
in the descending colon or
Sigmoid.
sigmoid colon, isn't it? Okay,
Yes.
proceed. Please proceed.
Shadab, one more question I have. Why do you think they said there is a growth after 6 months of follow-up? So what are the possibilities you can think? Whether do you think of a recurrence or something else?
6 months, sir. He was said to have a growth after 6 months of chemotherapy, sir. So probably there might be a missed synchronous lesion during the first presentation. It is unlikely to be a recurrence because if the disease has recurred after 6 months from the even as despite the therapy, is suggestive of aggressive tumor, sir. And but the patient has history of 5 years of asymptomatic history, sir. So unlikely recurrence.
Okay. Why do you think left side colon presents early rather than the right-sided colon? How the right-sided malignancy they will present to you?
Sir, right-sided malignancy is present with occult with anorexia, anemia, and easy fatigability, sir. They have occult loss of blood in stools. And whereas the left-sided colon are stricturous in presentation and present with obstruction, sir. So they present at an earlier stage when
That's the
compared to
only
the right.
reason. Do you have any other reason?
The right-sided colon is larger in diameter, sir, and the stools and the content of the right colon is liquid as compared to the left, sir. And the left colon is smaller in size compared to the right colon, so obstruction is They present more with obstructive features.
Okay, now he said he has what are the symptoms? He has colicky pain and altered bowel. What do you mean by altered bowel habits?
Sir, altered bowel habits is defined as the persistent change in the normal bowel routine of the patient in terms of frequency, consistency, and caliber of the stool, sir. It may be altering with, it may be increase or decrease in the frequency of passage of stools. It may be alternating with passing of loose stools and hard stools, or it can be alteration in the caliber of stools. He might be passing pencil stools.
Okay, fine. So, okay, continue.
Continue.
Past history is not a known case of diabetes mellitus, hypertension, epilepsy, tuberculosis, or asthma. Family history. He gives history of similar complaints of bleeding per rectum and mass per abdomen in his mother at around 40 years of age, for which she underwent surgery for the same, and she was advised for 6 cycles of chemotherapy but succumbed to the disease during this period. There is no history of any other malignancies within the family. Personal history.
Okay. Sorry for interruption.
Yes, sir.
So what is the significance of this family history?
Sir, the patient has a positive family history of colorectal malignancy within the first degree relative, sir. So it may be hereditary colorectal syndrome, or it may be a familial disease.
Which type of hereditary colorectal malignancy do you expect?
At this point, because of his age of presentation, sir, and his
Good.
past history, we can most likely it is hereditary non-polyposis colon cancer, sir, or
Very
Lynch
good.
syndrome.
Because it is younger age, quite younger
Yes,
age, isn't it? 40 years, 49 years, younger age group, and without any long-standing history,
yes, sir.
like bleeding per rectum or altered bowel habit, short history, isn't it?
Yes,
So
sir.
more probability goes in favor of non-polyposis colorectal malignancy, like HNPCC, isn't it? What is
Yes,
the
sir.
other name for HNPCC?
Lynch syndrome.
Lynch syndrome. Could be Lynch syndrome, isn't it? We will see. We will
Yes.
see later on. Okay, please proceed.
Personal history, the patient consumes a mixed diet. His appetite is reduced. Sleep is disturbed due to pain. Bowel and bladder habits are altered. He used to consume alcohol occasionally once in 15 days, and stopped 6 years back. There's no history of consumption of tobacco or any other substance abuse.
What you
Uh,
have to give more importance in personal history here, Shadab?
Sir, the consumption of any tobacco, alcohol, or any substances which may predispose to
No, alcohol, no much
cancers.
relation with the suspected case of colorectal malignancy, isn't it?
Yes, sir.
Tobacco, again, no much relation, though tobacco can cause any type of malignancy in human being.
Yes.
Less correlation in case of colorectal malignancy. You have to give more importance to diet,
Diet habits.
isn't it? So
Yes.
what type of dietary habits
Sir,
are more likely to cause CA, apart from family history, what's the family history?
consumption of processed meats, and
Yeah.
consumption of nitrate containing substances such as smoked meat predispose to the malignancy, sir.
Yeah. Smoked foods are any contents of nitrate.
malignancy.
They are more causing CA stomach rather than colorectal malignancy.
For colon
Isn't it?
malignancy, sir is asking specifically for colon malignancy. Which meat?
Nitrate will give rise to CA stomach.
Uh, red meat, consumption of red meat
Red
and
meat
processed
or
foods.
yeah. Raw non-vegetable diet, isn't it?
Yes,
Something like if they consume more of non-vegetarian diet compared to vegetarian diet. So that you have
yes,
to highlight here, isn't it?
yes, yes, sir.
So along with the positive family history, these environmental factors, dietary, they can add to it, isn't
Yes,
it?
sir.
Okay, please proceed.
Summarizing the history, here is a 49-year-old male who came with complaints of altered bowel habits in the form of intermittent episodes of loose stools associated with mucus since 6 months, colicky abdominal pain in the right lower quadrant since 3 months with history of loss of appetite and loss of weight since 3 months with previous history of bleeding per rectum for which he was operated and underwent 6 cycles of chemotherapy, and one follow-up was diagnosed to have growth in the colon with a positive family history of GI malignancy in the mothers. Based on the history, I would like to give a diagnosis of colorectal malignancies. Carcinoma of the colon. Carcinoma of the
Which
colon.
part of the colon? Which part?
Of the ascending of the right side of the colons.
Right side of the colon.
Yes. Right
What are the
side.
points? What are the points in favor of your diagnosis? Carcinoma of the right side of the colon.
He gives a history of altered. He gives history of reduced. Sorry, sir. He gives history of easy fatigability, sir.
That
And colicky type of abdominal pain and altered bowel habits and weight loss.
the colicky type of pain abdomen, you know, it will be there in case of intestinal obstruction, isn't it?
Intestinal obstruction, yes.
Intestinal obstruction is more common in case of left-sided malignancy,
Left-sided
colon
colon.
malignancy, and right-sided colon malignancy, isn't it?
Yes, sir.
So you have to tell some points in favor of your diagnosis, your suspicion of carcinoma arising from right side of the colon.
Yes.
Or will say carcinoma arising from left side of colon. What do you want to say?
Easy fatigability, sir. It might be due to
Any malignancy, any advanced malignancy can be there.
Shadab, what sir is asking you is tell out certain salient points with regards to why do you say it is a case of right CA colon or left CA colon?
See, what are the points in favoring
depending on
right sided
100% case
colon?
of because depending on your history, it is 100% a case of colorectal malignancy. Everybody will agree with this, isn't it? We want to know which part of the colon or rectum is involved, depending on the history.
Based on the history, patient presents with altered bowel habits.
Yes.
And with the mucus and blood, mucus and loose stools, and
that can be there even in left side of the colon also, isn't it?
yes.
You are given a complaint that is a right-sided lower abdominal pain, colicky abdominal pain in the right lower quadrant since 3 months.
Yes.
And anything to support to say it is a right-sided colon? How they will present your right-sided colon malignancies? You just now said.
Right-sided, they present with loss of weight, reduced appetite, and altered bowel habits.
In history itself, we have told, isn't it?
Yes.
In past, significant past history, you have told that patient has already undergone surgery, isn't it?
Yes.
Patient has already undergone surgery, patient had received chemotherapy, and you had suspicion of patient having left-sided CA colon.
Yes.
Isn't it? At that time.
Yes.
Now you are expecting recurrence. Isn't it? It is not
Yes,
a new case. It is not a fresh case of colorectal malignancy. It is a recurrent case.
Yes, sir.
Isn't it? Because it's not a benign case because he has received chemotherapy. He has received chemotherapy, 100% should be a case of malignancy. So when already he has undergone some sort of radical surgery for suspected malignancy, invariably they would have done left hemicolectomy, isn't it?
Yes, sir.
We may be wrong. We may be wrong. But since he has undergone radical surgery followed by chemotherapy, we assume that he might have undergone left-sided hemicolectomy, left hemicolectomy. So obviously he has to suffer from recurrence in the remaining part of the colon. Isn't it? That's how you can substantiate. Presently, he may be having right-sided colon malignancy.
Yes, sir.
Isn't it? Because patient is not having any records also with him.
Okay. Sir, I have some questions. So,
Please.
what do you call that malignancy which comes within 6 months or after 6 months?
Synchronous tumors.
No, are you thinking here synchronous metachronous or a recurrence? 3 questions. Whether do you think it is a synchronous malignancy or a metachronous malignancy or a recurrence? So explain each one of you. Which one you think this?
Sir, synchronous malignancies is when there is a new primary within 6 months of diagnosing of the first
No,
index.
synchronous is not a new primary. It is synchronous, as the name indicates. Synchronous is malignancy was there, which was missed.
Second
Yes,
primary, we can second primary.
Ah,
The same
second primary.
which was missed,
Yes,
isn't it?
yes. And
metachronous.
metachronous is the recurrent is the formation of a new primary after 6 months of the resection of the first index tumors. Sir.
Okay.
Uh,
Coming to the recurrence.
in recurrence, in this case, would be unlikely because of the long duration of history, sir. He had a recurrence 6 months after the first presenting complaint, sir. So, suggestive of aggressive tumor, followed by which 6 months he was asymptomatic. So, recurrence is unlikely, sir.
Why you think unlikely? Because what you
Recurrence,
said.
if recurrence after 6 months of surgery and chemotherapy suggestive of suggest the aggressive characteristic of the tumor, sir. So if the patient had a recurrence at after 6 months of the first surgery, following that he would gives history of not having any symptoms or apparently was in good health for a duration of almost 5 years, sir.
Okay. So you think of either synchronous or
Or
metachronous. Maybe
metachronous.
how could you say that the first surgery, maybe as sir told, maybe has come in obstruction, so maybe or may not be. We don't know what is it. So
Yes,
he has undergone surgery. Maybe the synchronous lesion may be missed. So they have told exactly after 6 months to undergo surgery. That itself indicates he had some lesion. So we
yes,
don't know whether it's a recurrence, unlikely to be a recurrence as per you. Okay.
yes,
It's just a speculations what you are doing it. Okay, fine.
Yes. And one more point, Dr. Shadab.
yes,
There
sir.
is some difference between the residual tumor and a recurrent tumor, isn't it?
Yes, yes, sir.
And to define it as recurrence, there should be some tumor-free interval.
Yes, sir.
Tumor-free, and it should be evidence-based. He has to
Yes,
undergo
sir.
some surgery, radical surgery, after which even if you do any investigation, there should not be any tumor
Yes, sir.
residue. After some specified time, that specified time varies for different malignancies. It may be
Yes, sir.
different for malignancy, different for CA stomach, different for CA esophagus, different for colorectal malignancy. Isn't
Yes,
it?
sir.
So after that tumor-free interval, if it recurs, reappears, then we call it as recurrence.
Yes,
Isn't
sir.
it? So in this case, within 6 months itself, they could find some evidence of malignancy. So
Malignancy.
it may be residual tumor also, as far as pointed out, can be
Yes, sir.
seen corners which might have been missed. There is every possibility of it,
Yes,
isn't
sir.
it? So you should understand the terms residual tumor and recurrent tumor.
Yes, sir.
It is residual or recurrent, we don't know. Because to call it as recurrent, I told there should be some tumor-free or disease-free interval,
Internal.
right?
Yes, sir.
Okay, please proceed.
General physical examination. Patient was examined with prior consents in a well-lit room with adequate exposure in supine position. A middle-aged male, moderately built and poorly nourished, conscious, cooperative, and well-oriented to time, place, and person, with a pulse rate of 78 beats per minute in the right radial artery with regular rhythm and normal volume in the right radial artery in the supine position, with a blood pressure of 120 by 76 millimeter of mercury measured in the right brachial artery in the supine position, who patient was afebrile on touch, with a BMI of 18.7 kg per meter square. Uh, Pallor was present. There's no icterus, there's no cyanosis, no clubbing, there's no generalized lymphadenopathy, there's no bilateral pitting pedal edema. Per
Okay.
Any other findings you want to look for in general physical examination? Dr. Shadab,
Yes, sir.
do you want to
Uh,
look for any other findings in general physical examination? Any relevant negative findings apart from this, whatever you have presented?
uh, No.
You have mentioned no generalized lymphadenopathy, isn't it?
Yes, there's no generalized.
Supraclavicular.
In its place, we expect
No
left specifically
supraclavicular.
supraclavicular lymph node.
Yes.
Because any intraabdominal malignancy, it can spread to left supraclavicular lymph node,
Yes.
isn't it? What is that
Yes.
called a sign? What is that sign called a?
Trojer's signs.
What is that lymph node?
Virtuous lymph nodes.
So can you explain how an intraabdominal malignancy can spread to left supraclavicular lymph node?
Sir, the thoracic duct empties into the in the left subclavian
Before
vein, sir.
thoracic duct becomes cisterna chyli, isn't it?
Yes, cisterna chyli, which drains into
Hepatic
the left subclavian and the lymph node adjacent to the vein gets involved.
There will be retrograde spread. Retrograde from that vein to that particular lymph node, isn't it? So
Yes.
specifically, we expect here in this case, there is no left supraclavicular lymphadenopathy instead of mentioning no generalized lymphadenopathy.
Yes.
Isn't it? Very good. Please.
Per abdominal examination, on inspection, the abdomen is flat, the umbilicus is central and inverted. Corresponding quadrants of the abdomen move equally with respiration. There is a fullness noted in the right lumbar, right hypochondriac, and the umbilical region, which disappears on head raising test. A midline scar measuring 7 centimeters is noted in the infraumbilical region, which is healed by primary intention. There's no cough impulse. 5 cruciate shaped branding scars noted in the right and the left hypochondrium, epigastric region, and the left side of the chest wall. There's no dilated veins, sinuses. There's no visible peristalsis. External genitalia appear normal.
Looking at the scar, Shadab.
Yes.
Go back.
What
Looking
are
at
those
the
5
scar.
cruciate shaped?
Looking at the scar. So what surgery could have been done? Like look at the scar now.
Sir, looking at the scar, the patient might have undergone segmental resection of the sigmoid colon or low anterior resection for upper rectal growths.
So unlikely because the incision is not gone above the umbilicus. So it's unlikely to be a hemicolectomy because they have to mobilize the colon, no? Hemicolectomy, left-sided hemicolectomy. So it may be a segmental resection or a low anterior resection. Even low anterior resection, they have to mobilize it.
Yes, sir.
So looking at the scar. Now coming back to your fullness. So according to you, you said it disappears on head rising test, indicating what?
This indicates it is the lesion is intraperitoneals.
Intra-abdominal. Okay.
Intra-abdominals.
What are those 5 cruciate shaped branding scars, Shadab?
Sorry, sir, didn't get you, sir.
5 cruciate shaped branding scars are there, isn't it?
Yes, sir. Patient gives that during in his childhood the branding was done, sir. He does not know the specific reason for this.
Usually branding is done for what? What branding usually?
Usually it is done for a history of any jaundice.
Jaundice, they tie something to the arm actually. Okay.
Maybe some sort of pain abdomen, isn't it?
Yeah, pain abdomen, chronic pain abdomen. Yes.
Okay.
Yeah.
Coming to palpation, there's no local rise of temperature. There is no tenderness. Abdomen is soft. A well-defined solitary mass is palpable in the right lumbar region, extending into the right hypochondrium and the umbilical region. All borders are felt. It measures 12 centimeters in the long axis and 10 centimeters horizontally. Superiorly, it is 2 centimeters below the right costal margin in the right midclavicular line. Inferiorly, it is 14 centimeter below the right costal margin in the right midclavicular line. Medially, it is 1 centimeter lateral to the midline, and the lateral extent is still the right anterior axillary line. The surface is nodular. It is firm in consistency. does not move with respiration. It is mobile in the horizontal direction and it is not palpable bimanually. Right direct inguinal hernia is noted. The other hernial orifices are intact.
No, you said the mass is mobile horizontally. You said doesn't move with respiration.
Yes, sir. Does not move with respiration.
So what are the masses that moves with respiration?
Masses that move with respiration are, sir, liver pathologies, splenic masses, stomach, small bowel.
Small bowel, does it move with respiration?
No, sir, sorry. Stomach and hepatic flexure and growth from the transverse colons.
No. Transverse colon will not move with respiration.
Masses arise from the organs which are in close proximity to the
With
under
the
surface of the
diaphragm.
abdomen, isn't it?
Yes.
So such organs you have to tell. Masses arise from such organs.
One
Okay.
point you said mobile in horizontal direction. So it is not moving in vertical direction, but it has a mobility in horizontal direction. So what
Yes.
it suggests?
It is suggestive of the mass arising from the ascending colon, sir.
Can it be okay? Transverse colon?
Uh,
Transverse colon you can move, no?
a transverse colon, it can be from the transverse colon, sir, but the location
Before,
is more towards the lumbar right side of the.
Transverse can come anywhere. You know that how transverse colon will be
Yes.
there.
Shadab, before
Yes.
going to the origin of the mass, site of origin
Yes.
of the mass, you have to tell plane of the mass. One thing you are told, that is
Yes.
head raising test, the mass becomes less prominent,
Yes, sir.
isn't it? That means it is an intra-abdominal mass, definitely not parietal mass. Okay. So in intra-abdominal, it can be intraperitoneal or retroperitoneal.
Yes, sir.
So what test you did to differentiate intraperitoneal from retroperitoneal?
Uh,
But there is possibility that it can be a retroperitoneal mass. In this case,
yes,
it
sir.
can be a retroperitoneal mass. So you have to do the examination methodically. Before coming to a conclusion, you have to
Yes, sir.
examine the patient and present it methodically. What is the plane of this mass?
Sir, in
And what
if
is that plane?
yes, sir,
Plane of half answer I have told already.
it is intra-abdominal, sir. In case of retroperitoneal masses, sir, when the patient is placed on all fours, in the position of all fours, sir, the mass does not fall forward, sir.
Don't
Whereas
say
in
knee elbow position.
knee elbow position.
You have to put the patient in knee elbow position. If the mass fall forwards, that means it is intraperitoneal mass.
Intraperitoneal.
Not falling forward, it is retroperitoneal mass. So what is your
Retroperitoneal.
finding in this case?
This,
Did you examine the patient in knee elbow position?
no, sir, I did not.
Sir, usually we don't ask them to do that. As you said, it is right, sir. Sometimes you can do. So
Yes,
usually knee elbow position, we don't ask them to do it. But you are right, sir. Whatever you said, okay. But the
there is
mass
possibility.
itself, it moves. The mobility with the horizontal mobility suggests it could be intraperitoneal, because if it is a retroperitoneal mass, usually lymph
Yes,
nodes or whatever, they
yes,
don't have any independent mobility, sir.
yes, yes, yes. So one point against retroperitoneal is this, whatever you are told, horizontal mobility, isn't it?
Yes, sir.
But as a rule, before starting your details of the examination further, you have to tell plane of the mass. In any
Yes.
abdominal case, any abdominal mass, it is a routine.
Yes.
Okay, first you have to
Yes.
differentiate is it parietal wall mass or intra-abdominal mass. Then is it intraperitoneal or retroperitoneal. By
Yes, sir.
default, you have to tell. Okay, right.
Yes, sir.
Please proceed.
There's no hepatomegaly, there's no splenomegaly. External genitalia are normal on palpation. On percussion, the mass is dull to percuss. A band of resonance is noted between the liver and the mass. Liver dullness is noted in the fifth intercostal space along the right midclavicular line. The liver span of measuring of 9 centimeters. There's no free fluid noted within the abdomen. On auscultation, the bowel sounds are heard and are normal. Per rectal examination, there is no palpable growth. There is no bleeding PR. The gloves are stained with yellow colored stools. Bilateral renal angles, there is no fullness. There is non-tender and are resonant to percus. There's no palpable left supraclavicular lymph nodes, and the spine examination is normal.
So you have mentioned there is no free fluid in percussion, isn't it?
Yes. Yes, sir.
What test you did to comment on free fluid?
Shifting dullness was done, sir.
No, before apart from that, shifting dullness
Uh,
will be seen in case of moderate fluid, isn't it?
yes, sir.
You even rule out minimal fluid also.
Minimal fluid, we have to elicit puddle signs, sir. Again,
Again,
the
you have to
patient is
examine.
straight on knee elbow position, and
Yeah.
percussion is done in the umbilical region, sir.
Yes. Clinically, if you want to mention that there is no clinical evidence of free fluid, you
Yes,
have
sir.
to ask the patient to assume knee position and you have to percuss around the umbilicus. Then only you
Yes.
can comment on this that there is no free fluid, isn't it?
Yes, sir.
Okay, good. Diagnosis.
Uh, Other systemic examinations are normal. Bilateral normal vesicular breath sounds were heard. No added sounds. Cardiovascular system was normal. CNS was no focal deficits. Diagnosis is carcinoma colon involving the right colon with the previous colorectal carcinoma, post-surgical excision and adjuvant chemotherapy with anemia with a positive family history of very colorectal malignancy.
Right.
Then we can ask
Because
questions.
all positive, so many positive findings are there in favor
Yes,
of
sir.
chronic malignancy,
Correct.
isn't it?
Yes, sir.
There are so many positive findings. How do you proceed with this patient? It's something like a problem-based case, isn't it? Diagnosis is
Yes.
already proven. How do you proceed with this patient?
I would like to confirm the diagnosis, sir.
Good.
And to confirm the diagnosis, I would like to go with colonoscopy and biopsy of colonoscopy and biopsy, sir. And
Okay,
to
Before
Shadab, before
colonoscopy,
doing, yeah, what you said is confirmation correct, but you said patient has, and practical point I'm telling you, patient has easy fatigability and he has this pain abdomen, colicky and loss of appetite, loss of weight. So you cannot directly jump into colonoscopy. So what you have
yes.
to do?
Would like to get blood evaluations first, sir. Complete blood
Hemoglobin.
counts to check for the hemoglobin levels.
Then,
Liver function test to look for the nutritional status of the patient, sir.
then
And
next.
next, I would like to do tumor markers of CA,
no, no.
carcinoembryogenic antigens, and baseline and renal serum creatinine levels, because I would like to plan CECT next.
If,
Okay.
what is the simple investigation to know the organ of origin? In this case, simple investigation.
First, basic investigation.
But you have to confirm that
Uh,
anatomical diagnosis, isn't it?
yes.
Anatomical
Ultrasound
diagnosis in the
abdomen
right
and
side of the
pelvis.
colon. Yeah.
Uh, uh,
Simple to USG abdomen, easily available,
USG,
isn't it?
yes. USG
Abdomen.
abdomen pelvis. I would like to.
Definitely confirm the anatomical diagnosis.
Yes. To look
Then
for
we can
the
witness
liver
for the
status
colonoscopy.
and free fluid in them.
Good, good. You can see the
So,
liver status also.
Yes.
Isn't it? Apart from organ of origin, peritoneal metastasis, free fluid, liver status, everything.
Yes.
Then comes fitness for
Then
colonoscopy. Next investigation would be colonoscopy.
colonoscopy.
Fitness for the colonoscopy, you have to do basic investigation like CBC,
Yes.
etc., whatever you have told, isn't it?
Yes, sir.
Patient is not fit, definitely you cannot do colonoscopy,
Colonoscopy.
right? Then what do you expect in colonoscopy? Or
On
whether
colon-
investigation have been done? Can you tell the investigation findings?
yes, sir. Sir, just a minute before telling Shadab, what sir said is right. So first is ultrasound that will act as a roadmap for you. So if
yes, sir.
ultrasound, as sir said, it will tell you about the liver metastasis, ascites, organ of origin. So all those things will come to know. That acts as a roadmap.
Yes.
Then, because patient has other things like anemia and everything, correct the anemia. Then look for urea creatinine and get a CT scan done. Then
Yes.
once you know that where is the growth, then you plan for a colonoscopy and correct the anemia. Then you do a colonoscopy and do a biopsy. Okay.
Biopsy. Yes.
So tumor markers, everything you can do. Okay. Don't directly say colonoscopy as a first thing.
Yes.
Ultrasound, then other things,
Uh,
then the colonoscopy. Okay.
colonoscopy. Yes.
Okay, fine. Now, what was the colonoscopy report?
Colonoscopy report showed an ulcerative growth noted in the ulceroproliferative growth
Ultrasound,
noted in.
ultrasound. Go in order. Go to
Yes.
ultrasound first. Ultrasound was there.
Yes, sir.
Where is the ultrasound? Yeah.
The ultrasonography abdomen. Sorry, sir. Uh, in USG abdomen pelvis, there was a circumferential hypoechoic wall thickening of the large bowel loop in the right iliac fossa, measuring for 6.3 centimeters with maximum wall thickness of 1 centimeter, causing distal luminal narrowing. Surrounding mesentery appears hyperechoic. Similar morphological thickening noted in the large bowel loop in the right hypochondrium for a length of 7.9 centimeters and a thickness of 12 mm. The liver appears to be normal and there is no free fluid in the abdomen.
Okay. So there is no liver metastasis, no ascites. Next.
Yes. Next, the colonoscopic reports. The colonoscopy report is
Martin, somebody is there, man. Martin,
Martin, could you please unmute the person?
unmute the person.
Done, sir.
Mute, sorry, mute.
yes.
Shadab, continue.
The colonoscopy report showed an ulceroproliferative growth in the transverse colon, sir, and the scope could not be negotiated beyond the growth. And there was a circumferential narrowing at around 15 centimeters from the anal versa, suspected anastomotic site from the previous surgery, sir. And the biopsy from the colonoscopy was reported as a well differentiated adenocarcinoma.
Okay, what is the CT scan report?
In the CT, there's a long segment asymmetrical heterogeneously enhancing circumferential wall thickening seen involving terminal ileum extending into the ileocecal junction and cecum with resultant mild luminal narrowing. The length of the involved segment measures 70 mm with maximum wall thickness of 15 mm. Mild pericolonic fat stranding is seen with few subcentimetric lymph nodes, no significant dilation of proximal ileal loops. Similar heterogeneously enhancing circumferential long segment wall thickening is seen, extending from hepatic flexure to proximal transverse colon for a length of 83 mm with maximum thickness of 22 mm. Associated pericolonic fat stranding is seen. New enlarged pericolonic lymph nodes noted, largest measuring 18 into 11 mm. There's no significant dilation of proximal large bowel loop seen. Multiple enlarged and variable size mesenteric group of lymph nodes noted showing a normal homogeneous enhancement on post contrast study, the largest measuring 19 into 10 mm. Sir.
Okay, fine. Now there is no liver metastasis, no
There is,
ascites. So as per
there
the
is,
CT, you have two growths.
yes.
One is in the hepatic flexure extending into transverse colon. Another one is in the cecum.
Cecum, sir.
Okay, now
And there is no infiltration of the surrounding structures.
Yeah. Few lymph nodes
what
are there.
structure are important when you have a
Yes.
growth in the upper part? Which structure you are looking?
Infiltration into the duodenum, sir. Right ureter and the right gonadal vessels.
Okay, so it is a synchronous lesion. There are two lesions.
There are two lesions, sir.
Okay.
Okay. I would like to proceed with this patient. Dr. Shadab.
Yes, sir.
Shadab. So
As based on the reports, sir, there is no based on the CT report, there is no infiltration of the surrounding structure, sir, suggestive of that the tumor is resectable. So I would like to go ahead with the extended right hemicolectomy, sir.
You told you want to get some tumor markers also, isn't it?
Yes, sir. Baseline
What is the
tumor
role of tumor
markers.
markers? What is the role of tumor markers here?
Tumor markers, it helps in to
First, tell
assess
us what is the tumor marker, what is the tumor marker, and what is its significance? Which tumor
uh,
to get assessment?
I would like to get embryonic antigen, sir. Uh,
CEA, very good.
CES. It is not uh, it is a oncofetal glycoprotein, sir, that is
Right,
expressed during fetal life, sir.
right.
A normal value of CA does not rule out malignancy, sir. However,
Right.
baseline CA is required to compare to assess for recurrence post surgeries.
Yeah. Post-treatment,
Post
post-treatment
treatment.
residual or recurrence. To
Yes,
comment on post-treatment residual or recurrence, you want to know basal level, isn't it?
basal levels. Yes, sir.
That is the role of tumor markers. Good. Okay. What is your plan?
Shadab,
Plan.
one more thing before
Yeah.
the plan, just 1 minute. Whether how do you counsel the patient? Because patient is already undergone surgery, now has come with this problem. So before taking him surgery, counseling. So what are the things you tell the patient?
Uh, Before going ahead with the procedure, sir, I would like to counsel the procedure patient regarding the extent of resection, sir, uh, of what all structures are going to be removed, and if the possibility of unresectability of the tumor, if there is intraoperative evidence of infiltration, or if there is a involvement of the liver or peritoneal mets, sir. And
Sure, if it is infiltrated, then you feel it is unresectable. Means
yes,
which one?
if it is infiltrated, we would it if it is infiltrating the surrounding structures, or if there is uh, uh, an involvement evidence of involvement of the peritoneal or liver metastasis, sir, we cannot go ahead with the resection, sir. It directly upstages the disease to stage 4, sir.
Even
So
in stage 4, see, even peritoneal mets you can do because it is going, you can resect the tumor.
yes,
I asked you
uh,
unresectability. Cure is
involvement.
different, unresectability is different.
It is involvement of the duodenum. If the
If,
duodenum is involved, then we cannot.
if it is superficial involvement, you can shave it, but if it is a complete involvement where it is fixed to the duodenum, you cannot do anything, then you can do just a bypass and come out.
Yes,
Almost in case of GI malignancy, Shadab,
yes,
if the
sir.
tumor is resectable, right? Tumor is
Yes,
resectable, better you do resection because it acts as a good method of palliation.
yes,
Good method of palliation is by doing resection itself, provided it is resectable and patient is fit for the surgery.
yes,
Isn't it? So that communication skill is also very important in this case. As sir has rightly pointed out, since it is already case, recurrent case, the patient has undergone already chemotherapy, isn't it? It is very difficult to assure 100% cure.
yes, sir.
Isn't it? Very difficult to assure. You cannot give assurance,
Yes, sir.
but you can give some hopes to the patient. Isn't it? Counseling is very important in this case. So
Yes, sir.
all possibilities you have to explain to the patient regarding inoperability, regarding unresectability, regarding even
Recurrence.
on-table mortality sometimes,
Yes,
and post-operative complications and post-operative need for again new adjuvant chemotherapy or
adjuvant
sometimes
chemotherapy.
radiotherapy.
Yes, sir.
Isn't it? So all those
Yes,
things you have to counsel well before starting the treatment.
yes.
Isn't it? Good, very good. Can you tell us the plan of treatment?
The plan of
Suresh sir,
treatment.
Suresh sir, I think it is 5 minutes to 9.
No, it's okay, sir. I
In
will be
5-10
there
minutes, I
till
think we'll be
9
able to
o'clock.
conclude, isn't it? We'll go to next case. Can
Next,
you tell
next.
your plan of treatment, Shadab?
But I would like to optimize the patient before going ahead with the surgery
Okay.
in lieu of his low HB level, sir. I would like to transfuse uh, blood and give adequate albumin injections to optimize his nutritional status, sir. And then I would plan for an elective extended right hemicolectomy, sir.
Okay, can you show the surgery? What was the finding? Just
Intraoperatively, the growth was noted in the proximal one third of the transverse colon and in the cecum, and both the growths were adherent to each other. The hepatic flexure and splenic flexure were normal. There was no free fluid within the abdomen. The liver was normal on examination, sir.
okay. Just tell me what is hemicolectomy. Okay, these are the intraoperative photographs.
Images.
Okay. Just show it. What is it?
Sir, on the top right corner, sir, there is the specimen, sir, which shows the ileum, the ileocecal junction, and the cecum and transverse colon, which are adherent to each other, sir. Uh, they're crumpled and adherent to each other. And the hepatic flexure is within this mass, sir.
Okay.
And in the lower segment, this shows the gross specimen, histopathological specimen, sir, which is cut open longitudinally. And in the 11 o'clock position, pointer is pointing towards the growth in the transverse colon, whereas at around 7 o'clock position, the second pointer indicates is pointing towards the growth in the cecum, sir. And in the last image in the bottom corner, sir, in the bottom row is showing normal mucosa between the two lesions, sir, suggestive of synchronous malignancy in this patient.
So what you suggest synchronous? Why not? It is a infiltration of colon malignancy, like cecal malignancy infiltrating transverse colon.
Sir, it is the two lesions are separated by healthy normal mucosa, sir.
Okay, fine. So infiltration usually comes from outside. So
Yes, sir.
mucosa may be a normal. So, but as it says too, when you do a histopathological study, you will come to know that both the mucosas are involved. So indicating it is the two synchronous lesions.
Yes,
Okay.
sir.
So what? Just tell us what is hemicolectomy, what is extended hemicolectomy.
Hemicolectomy is the resection of the distal terminal part of around 10 to 20 centimeters of the ileum, cecum, appendix, ascending colon, and the proximal one third of the transverse colon, sir. Whereas in extended hemicolectomy, up to the proximal two third of the transverse colon is resected, sir. It is based on the vascular supply of the colon. So the in right hemicolectomy, the ileocolic, right colic, and the right branch of middle colic vessels are ligated. Whereas in the extended right hemicolectomy, along with the ileocolic and right colic, the middle colic vessel is ligated before its branching, sir.
Okay.
Very good.
Fine.
Okay, you have done good surgery. Anastomosis between
Ileum and distal transverse colons.
you were what are different types of anastomosis, you know, and what was done in this case?
In this case,
Hmm.
in this case, side to side isoperistaltic anastomosis.
Side to side periclas was done.
Yes, sir.
Okay. Okay. Then, so you have done good surgery. There is no anastomotic leak. Post-operative and uneventful. Post-operative period.
Yes.
Okay. Then further
Uh,
treatment.
Now, further, based on the histopathological report and the IHC markers for MMR, sir, DNA mismatch repairs, we would
Right.
like to plan if the patient would receive adjuvant and or adjuvant chemotherapy. But
Please, Rosie.
Yes.
sorry, sir.
Yeah, you have to decide regarding the chemotherapy whether to, because
Chemotherapy.
already patient has received a chemotherapy. Now it is the second chemotherapy. So for
Yes.
that, before that, you have to do that MMR and all those things. Then you decide whether patient needs a chemotherapy with all lymph node status and everything.
Yes, sir.
Second thing is what do you want to do? Because both the mother and a son had the malignancy at a younger age group. So how do you counsel the family, patient,
Like
attendants, or
to
anything?
a genetic counseling should be done for the members of the family, sir. and screening should be started for all the for the first degree relatives of the first degree relatives of the patient from 20 years of age with colonoscopy and imaging.
Yeah, there is role of screening colonoscopy. The
Screening
family
colonoscopy.
members, isn't it?
Yes.
Screening
Yes, sir.
colonoscopy. Do you know the ISC markers for HNPCC? Shadab?
Sir, PMS2, MSH2, MSH6, and MLH1. Sir.
Okay, you have to get their estimation, isn't it? ISC
Yes.
marker. Very good.
Sir, I think another 5 more minutes will wind up this case, sir. We have got one more case.
Sure, sir. Sure, sir. Shadab, any doubts you have? Any questions you have from your side, Shadab?
Sir, based on the history, the patient presents with he was told to have a malignancy 6 months after the chemotherapy and surgery, sir. So,
Right.
does that put the patient, the lesion which he had 6 years earlier, into a metachronous lesion, sir? And in this case, now the lesion he presented is synchronous, sir. So, is it a metachronous or a synchronous lesion?
So the point is 6 months, no, that is the problem, exact 6 months. So if it is after 6 months, we consider it as a metachronous. Within 6 months, we consider it as a synchronous lesion. So
There is a
what
problem
I
from the
feel is
patient
it's
side.
a synchronous lesion which has
Probably.
missed during the primary evaluation. That is what I think.
In this
Sir, we
case,
have
patient
one
also
question
comes to
in
the
the chat box.
Yes,
sure,
It
sure.
is, what is oligometastatic colon cancer, sir? Shadab, you know about it? What is oligometastatic colon cancer?
No, sir, I'm not aware of.
Some disturbance is there.
Sir, I think we'll go ahead with the next case, sir, with your permission.
Okay. Please, sir. We request our second presenter.
Sir, thank you very much. Sir, I have to leave.
Yes, sir.
I thank the
Yes,
ASI for giving me the opportunity, sir. Thank you very much, sir.
Thank
Thank
you.
you, Naz madam.
Yes, sir. Thank you, Dr. Suresh, sir. It
Thank
was
you,
a real
Manjunath, sir.
nice session, and we wish you a happy journey since you're traveling, I think, isn't it?
Yes, ma'am. Yes,
Yes,
ma'am.
sir. Thank you.
Thank
Happy
Happy journey,
journey.
Dr. Suresh, sir. Happy journey.
Thank you, sir. Thank
Thank
you
you
very
so
much.
much, sir.
Thank-
Yes.
thank-
Bye, doctors.
Bye. That's very nice. I
Bye.
May I request now the second presenter, Dr. Gazal?
just Dr. Sangamesh, let
Yeah, ma'am.
answer those questions, no, so that let the questions be answered. I think there are some more synchronous tumors have been answered. Then this oligometastatic, that is 1 to 5 metastasis in 1 to 2 organs, and it is still a treatable cancer, unlike multiple metastasis. And then I think something about the nutritional problems also to be considered following an ileocholic resection. So what nutrition supplement you have to give? So these are some of the questions I think will be
The
asked.
mandatory, you have to get LFT as a
LFT,
with the
yes.
part of albumin, total potential albumin, madam.
Yes. And B12 deficiencies are common in
Good,
these
good.
patients. So B12
I
supplement.
think, ma'am, in the history part, he just missed about Karnofsky's grading. And they should also, the PG should also know about ERAS in colon cancers.
Yes.
And role of laparoscopic surgery in such cases has to be discussed, ma'am. Like, I think students should know, not discuss, but the student should know. And
Yes.
margin of clearance and some more things.
Yeah.
So these are some of the things I think which need to be added on. Anyways, ma'am,
Well
thank you,
presented,
Shadab.
yeah. Dr.
Thank you,
Shadab,
sir.
really well presented. Most of the questions answered. Congratulations.
Well done, Dr. Shadab.
Thank you, ma'am.
Yes.
Well done, Dr. Shadab.
Thank you, sir.
Only one drawback I would say is you should show your videos. You should show your face while presenting so that you get that confidence while presenting.
Yes, sorry.
Okay.
Thank
Yes. Okay. Yeah. Dr. Sangamesh, next.
Yeah, Dr. Gazal, are you there?
Yes, sir.
Yeah, could you please start sharing your screen?
Yes, sir.
Yeah.
Good evening, everyone. My name is Dr. Gazal Gautam. I'm a junior resident in Department of General Surgery from Sri B.M. Patil Medical College, Hospital and Research Center, Vijayapura. The topic of my case presentation is peripheral vascular disease. Here I am presenting a case of Mr. XYZ, aged 62 years, who hails from Tajpur, Vijayapura. who has received formal education of 10th standard and is a retired military physical trainer. He belongs to the lower middle class according to Swami scale. He presented to us with chief complaints of blackish discoloration of second, fourth, and fifth toes of right foot since past 16 days, and complaint of wound and pain over the right foot since past 12 days. History of presenting illness. Patient was apparently all right 16 days back when he noticed blackish discoloration of second, fourth, and fifth toes of right foot, which was gradual in onset. First notice in fifth toe, followed by fourth and second toes as well. Non-foul smelling. And the discoloration started at the tip of the toe and further progressed to affect the complete toe. Patient also gives history of trauma with a stone over right foot 12 days back, after which he developed a bleb of approximately 5.2 centimeter, which burst spontaneously, and a wound developed over the same site, which was not associated with any discharge or bleeding. Patient also complains of pain over the wound, which was insidious in onset, aching type, present continuously, aggravated with movement, and relieved temporarily on taking medication. Patient does not give history of any increase in pain severity at night. No complaints of claudication pain in calf or thigh. No history of fever. No history of tingling or numbness in the lower limbs. No history of weakness or difficulty in walking. No history of similar complaints in opposite limb. And there is no history of transient blackout, blurred vision, chest pain, postprandial abdominal pain, or impotency. Patient is a known case of type 2 diabetes mellitus since past 10 years on tablet metformin 500 mg BD. Moving on to past history. Patient has undergone debridement and split thickness skin grafting over left lower limb 1.5 years back, which happened due to road traffic accident. There is no history of cerebrovascular accident, heart disease, previous MI or myocardial infarction or chronic kidney disease. No history of other previous surgeries like angioplasty, bypass surgery, amputations, or surgeries for ulcers, thrombosis, or embolism. There is no known drug allergy. Patient consumes a mixed diet. His appetite is normal. Sleep is adequate. Bowel and bladder habits are normal and regular. Patient is a cigarette smoker, BD smoker, and has been smoking since past 30 years, 8 to 9 BDs per day, with a smoking index of 270. He is also a chronic alcohol consumer, 250 ml 2 to 3 times per week since past 35 years.
May I interrupt you, Dr. Gajal?
Yes, sir.
And so what is the importance of habit smoking in this patient, which is more significant here?
Sir,
Smoking index?
smoking index of more than 300 is usually considered to be a causative factor for PVD, sir. It is the most important modifiable risk factor. How it affects or causes PVD is nicotine, which is a part of the smoke released by cigarette. It causes vasoconstriction by release of adrenaline and noradrenaline. Apart from that, it also increases LDL oxidation, which further progresses atherosclerosis. It also leads to formation of carboxyhemoglobin, which reduces tissue perfusion by oxygen. Free radical formation is noted by the contents released by smoke, which again further delay the tissue healing in the ulcers.
Very good, Rosie. It is a very important factor in this patient, isn't it?
Yes, sir.
Very good. Proceed, please.
Patient is married and is father of 3 children. There is no history of similar complaints in his father or brother. No history of cerebrovascular accidents, heart diseases, or diabetes mellitus in family.
Why you want to rule out this similarity in only father and brother? Why not other family members? You have specifically mentioned it, isn't it?
Yes, sir.
No history of similar complaint, father or brother. What about mother, sister, other family members? Tell us significance of this
Hello.
family history.
Yes, sir.
Tell us the significance of this family history.
Sir, if there has been atherosclerosis or incidents of cerebrovascular accidents or heart diseases in the parents, it increases the chance of the patient himself getting the disease.
Now, why you have specifically mentioned only father and brother? I'm asking. Any specific reason?
No, sir.
No, because nowadays we are seeing many females smoking, isn't it?
Yes, sir.
Especially in
Yes.
corporate places, the incidence of smoking is higher in female than males.
Yes.
It's a recent trend in the social gesture. So don't rule out females, isn't it?
Yes.
And there can be genetic predisposition to any of the vascular diseases.
Yes, sir.
It can be atherosclerosis, or it can be some types of autoimmune disease like vasculitis, isn't it? So don't specifically mention only male genders,
Yes.
right? Okay, please.
Yes. Summarizing the history, here is a 62-year-old male who is a chronic smoker and alcoholic. Known case of type 2 diabetes mellitus since past 10 years with 16 days history of dry gangrene of right foot involving second, fourth and fifth toe with ulcer over dorsum of right foot post-trauma. Moving on to...
Wait.
Yes.
Let us discuss something.
Yeah.
So what made you to diagnose it as a case of chronic peripheral vascular disease or chronic peripheral arterial disease? Though history is there only since 16 days, isn't it? Gazal, can you hear me?
Yes, sir.
History is there only 16 days, isn't it?
Yes, sir.
Even though 16 days history is there, you are labeling it as chronic disease.
Yes, sir.
Why? Why it can't be acute?
Sir, patient does not, sir, if it is acute, it may be due to embolus or traumatic, but there is usually association of 6 P's with acute history, sir, whenever we say. So since there is no presence of paresthesia or based on history, patient does not give any tingling numbness history, does not give history of cold limbs.
No, Gazal,
Yes.
you gave 16 days history of dry gangrene. But actually, if you go to chief complaints, when is it? That is also 16 days, sir.
Yes,
Oh,
sir.
only blackish discoloration you are given. Right.
Yes, sir.
How to explain this? In acute PVD, most of the time onset will be acute, isn't it?
Yes, sir.
Something like sometimes it can be sudden onset also.
Yes, sir.
Sudden onset of severe pain. Maybe because of acute thrombus or acute embolism, isn't it?
Yes, sir.
How to explain this? How to say that it is a chronic disease? Depending on history of presenting illness. What is one more important significant factor in this patient?
Sir, patient is a known smoker, sir, and has diabetes mellitus.
Yeah, that you have to give more importance, isn't it?
Yes.
That has to be correlated. Patient is also a known case of diabetes mellitus. So how the symptoms will get masked in case of diabetic patients?
Sir, due to presence of diabetic neuropathy, the ischemic pain of peripheral vascular disease might get masked.
Yeah, many a time the symptoms of chronic peripheral vascular disease may go undetectable, isn't it?
Yes.
They may get masked because of presence of neuropathy.
Yes, sir.
Isn't it?
Yes, sir.
Anything else?
This kind of a presentation is quite possible in diabetics, as sir said. Now, what makes you say what about claudication pain? Did you ask for claudication pain?
Yes, sir.
Yes, you did. I saw that. So how do you define a claudication pain? This is an important question. We need to know these things. What is a claudication pain? How do you define it?
Yes, sir. Claudication pain is a severe crampy type of pain in
Good.
muscles, usually calves, sir, which may or may not force the patient to take rest. It occurs due to accumulation of metabolites and substance P due to the poor blood flow and is reproducible in nature.
Reproducible nature is a very important thing. And you said it is, and where is it usually? Does it have to be felt in the calf always?
No, sir. It may occur in foot, calf, thigh, or buttocks, depending on the site of occlusion, sir.
Usually below muscles, below the level of occlusion. So that is what where you get claudication pain. Now you said there is pain there, and we also thought that it is a diabetic and that he might present with, even though if he has a chronic disease, he may not have symptoms. So is your patient very active and ambulant?
Sorry, sir, I didn't
Active
understand.
and ambulant, walking around,
No,
normal
sir.
lifestyle?
Sir, he has a normal lifestyle, but patient himself says that after retirement, he has a sedentary lifestyle as compared to before.
No. Sometimes patients with difficulties in ambulation may not develop a pain that can reach to a level of claudication.
Yes, sir.
That is the reason it's important to know what is his lifestyle, whether he's normally ambulant or is he restricted by any reasons. That is one. And the second pain that you said about, can it be rest pain? Rest pain. The pain you described. What have you described in pain? History of present illness?
Sir, it is insidious onset aching type pain, which is present continuously, aggravates
So
with
when you say
movement.
insidious, what do you mean by insidious? And how long is there any time duration to say insidious? 16 days history.
Yes, sir.
So what do you mean by insidious?
Sir, insidious means something
In
that
terms of
has
duration.
yes, sir.
In terms of duration, you have to tell. See, onset can be sudden, onset can be acute, onset can be gradual, onset can be insidious, isn't it?
Yes, sir.
Depending on the duration. Sudden in onset means all of a sudden, isn't it? Acute means you can say in sometimes hours or days. Gradual in onset again in terms of days or weeks. Insidious means usually in terms of months or years. Long term onset.
Yes.
Long history of onset. Here history is there only in 16 days.
Yes, sir.
Isn't it? That too patient has developed pain after history of trauma. Not the
Yes,
pain,
sir.
history of pain is not there since 16 days, is there since only 12 days.
12 days, sir.
And the trauma seems to has happened after he developed Blackhead discoloration.
Yes, sir.
Okay, so is it rest pain then?
No, sir.
No. What is the definition of
Why
rest
cannot
pain
be
and what
rest pain?
clinical features you get?
Sir, in rest pain, there is continuous aching type of pain, sir. Severe
Continuous?
in aching type of pain. Severe
Aching,
in
is it?
Yes, sir.
Okay. Another description of pain.
Present continuously even at rest.
It is intractable pain. Very severe form of pain. Okay.
And it occurs due to ischemia of the somatic nerves, sir, of the vasa vasorum.
Okay. Where does it happen? Site?
It may happen in foot, sir, commonly, or even calves. And it aggravates on lying down.
Are you sure it happens in the calf as well? Rest pain?
Sir, more commonly it happens in foot, sir.
Foot, which part of the foot? Heel? Ankle?
No, sir. Dorsum.
Dorsum? Or the toes?
Tips of the toes or dorsum?
Tips of the toes, sir.
Wherever is the occlusion, ultimate rest pain, whichever develops, is results in most distal part of the foot. Usually begins in the toes. Okay. Are there any relieving factors?
Yes, sir. Hanging the leg down the side of the bed helps in relief of rest pain to some degree. Due to gravitational action, the blood flow increases, sir, in when patient hangs the leg down the side of the bed.
Yes, it may not improve the circulation. I mean, maybe there is some amount of patient certainly feels better with that. And you might also see that patients give typical history of sitting in the chair when they want to sleep. They don't lie down on the bed. They sit in a chair and sleep. And their sleep is disturbed. And the patient will not be very comfortable to speak to you considering that he's having severe pain and he has not slept, he's disturbed, right? So that's a typical history. So sleep is also a very important history you should be taking when you take history. Speak about it. Did you mention it?
Yes, sir.
Okay.
So probably in this
Right.
case, because of his sedentary lifestyle, non-ambulatory sedentary lifestyle, and comorbidity of diabetes mellitus or neuropathy, the symptoms of intermittent claudication might have been masked, isn't it?
Yes, sir.
Okay, do you know the grading of intermittent claudication?
Yes, sir.
Clinical grading. What is that?
Yes, sir. Boyd's classification, sir.
Right.
Grade 1 is when there is development of pain on walking up to a certain distance, which if the patient continues to walk, the substance P and other metabolites wash away due to the presence of adequate blood flow, and patient can continue to walk. In grade 2, pain develops after walking a certain distance, and patient can walk with effort. And in grade 3, patient has to stop to take rest to be able to relieve from the pain.
Grade 4. What is grade 4?
So for Boyd's classification, only 3 grades are there.
What if there is 4th grade also? What already we have discussed?
Rest pain, sir.
Yeah. Rest pain is the grade 4. That is considered grade 4. What is the cause for rest pain? What is the cause for rest pain?
Sir, ischemia of the somatic nerves, the vasa vasorum.
Vasa nervosum. The blood vessel supplying nerves is called vasa nervosum. So ischemia of the nerves, isn't it? Even nerves also need blood supply for their vital function. So that cause that is also called as crying of the dying nerve, isn't it?
Yes.
Last is very good, very good.
Dr. Gazal, where is he likely to have rest pain if at all he has one? Which toes in this patient?
Sir,
second,
in this
fourth, and fifth?
No, sir, in the first and third, sir.
Okay. Right. Right. Okay. Now,
sir, there is one question in the chat box by Dr. Prashant Tupchi. He asked, why not it's a wet gangrene, except that she has no fever, since patient is a known diabetic also to the PG.
Yes, sir. Sir,
this was the next question for you.
You have not yet examined the patient. Gazal, you have not yet examined the patient. Why it is not a very good question.
Sir, based on history, patient does not give history of foul smelling, discoloration. Neither there is presence of any discharge from the gangrenous site.
There is no discharge, one thing. What is one more important thing? To rule out wet gangrene, history-wise, symptoms-wise.
Sir, foul smelling nature, sir.
Okay, that is one other thing, one more important thing. As the term itself indicates, dry gangrene. In case of dry gangrene, it will be dry, shriveled, mummified, isn't it? What will be the wet gangrene?
Sir, it will be
apart from being black in color. Yeah,
yes,
apart from being black in color, it will be edematous, it will be swollen.
Yes.
So that history you can elicit from the patient.
Yes.
Is there any edema of the limb? Is there any swelling of the limb? Isn't it?
Yes.
Because many times in diabetic patients, symptoms go I told masked. Symptoms like pain, symptoms like fever, May not be
Yes.
there.
And another important factor is that it is not rapidly progressing. It seems to be restricted to the distal part of the foot, isn't it?
Yes, sir.
Yeah. Only 3 toes.
Okay. Well, you've
Okay,
got
please.
most of the things there. Yeah, proceed.
General physical examination. Here is a 62-year-old male patient, moderately built and nourished, conscious, cooperative, and well-oriented to time, place, and person. Pulse rate is 72 beats per minute in right radial artery with regular rhythm, normal volume and character, no radioradial or radiofemoral delay, no vessel wall thickening. Blood pressure is 130 by 70 mm of Hg in right brachial artery in supine position. Respiratory rate 26 beats per minute. Afebrile. BMI of 29.74 kg per meter square. There are no signs of pallor, icterus, clubbing, cyanosis, edema, or lymphadenopathy.
Why you want to rule, why you have mentioned about radial and radiofemoral delay in this patient, Gazal?
Sir, to rule out any radial delay, to rule out the upper limb arterial occlusive diseases, and radiofemoral delay to rule out diseases like coarctation of aorta, aortic dissection.
Okay. Though it is not a routine in any case, since it is a peripheral vascular disease, I think you have examined for this, isn't it?
Yes.
So if it is not there, you need not mention it. If it is there,
Okay.
you have to highlight it, isn't it?
Yes.
Okay.
Okay, so what are the features or signs we can elicit in case of atherosclerosis in general physical examination? What are the signs?
Sir,
Risk factors for atherosclerosis.
Sir, there will be lipid deposition over the eyelid, sir. Then,
Any specific term?
sorry, sir.
You have measured the pulse rate in radial artery. You have measured the pulse rate in radial artery, isn't it?
Yes, sir.
So what do you want to look for? Already you have mentioned that.
Sir, vessel wall thickening may be
Thickened vessels, you may
yes,
feel them, isn't it?
yes,
They'll be felt like rigid cord like. And
yes,
all
sir.
the peripheral pulse you can feel for vessel wall thickening.
Yes, sir.
Okay, so those signs of dyslipidemia also you said. Is there a specific term for that? Are any skin changes? Okay, something like xanthelasma, xanthoma. Yes, there is a message in the group already. Dr. Taukir has answered it. Okay, proceed.
Patient examined after explaining the procedure and taking informed consent in a well-lit room with parts adequately exposed from anterior superior iliac spine to the tip of toes in supine position. On inspection of right lower limb, attitude of the patient was laying comfortably in supine position. Dry, shriveled, blackish, discolored second, fourth, and fifth toes were noted with line of demarcation. Mottling noted over ventral aspect of third toe. Solitary ovoid-shaped ulcer of 4 by 2 centimeter is seen over dorsum of right foot with which is extending from the base of fourth and fifth toes till midfoot with well-defined margins, sloping edges, slough seen at the floor of ulcer with surrounding skin peeling noted. A scab of 3.1 centimeter is noted over dorsum of right foot, 2 centimeter distal to the ankle joint. Below knee, the skin over the leg appeared to be thin, lusterless, with loss of subcutaneous fat, reduced hairs. Nails were brittle with transverse ridges. There is wasting of calf muscles over the right side. Burgos postural tests, since the toes are gangrenous, they already indicate severe ischemia. Capillary filling time was more than 20 seconds. Venous refilling time was 10 seconds. And the veins were guttered with delayed refilling. Palpation of right lower limb. The right foot is cold as compared to the left foot up till mid-thigh. Gangrene of second, fourth, and fifth toes with shriveled and mummified appearance, with demarcation line at the base of toes dorsally, extending 2 cm below the base of fourth and fifth toes ventrally. A solitary ovoid ulcer of 4 by 2 cm over dorsum of right foot, extending from the base of fourth and fifth toes till midfoot, with well-defined margins, sloping edges, slough at floor, base made by tendons and muscles, non-indurated. There is loss of movement at metatarsophalangeal joints, capillary refilling of 7 seconds, venous refilling of 10 seconds. No oscillatory movement of foot was noted on performing the crossed leg test. On checking the peripheral pulsations over the right side, dorsalis pedis, anterior tibial, posterior tibial, and popliteal artery were not palpable. Femoral artery was feeble, while over the left side, dorsalis pedis, anterior tibial, and posterior tibial were not palpable. Popliteal and femoral were feeble. On motor examination, tone and power was normal. Bulk of the muscle over right calf and thigh were less as compared to left side. On sensory examination, there was hyperesthesia of right foot. While crude and fine touch, pain sensation, temperature sensation were normal, 2 cm above the ankle. Plantar reflex was absent on right side. Ankle and patellar reflexes were present bilaterally. Regional lymph node examination was normal. On examination of left lower limb, scar mark of previous surgery was noted. Signs of ischemia were noted. Burgess, on performing the Burgess test, marked pallor was noted at 45 degrees. Capillary filling time and venous refilling are delayed. On auscultation of all arteries, no bruit was heard. Systemic examination on cardiovascular system, normal heart sounds were heard with no murmurs. Respiratory system, normal vesicular breath sounds heard bilaterally. Per abdomen was soft, non-tender, no mass or organomegaly. Bowel sounds were heard. Central nervous system, higher mental functions were intact, no focal deficits noted. Summarizing the case, a 62-year-old male, chronic smoker and alcoholic, who is a known case of type 2 diabetes mellitus since 10 years with dry gangrene of right foot affecting third, fourth, and fifth toes since 16 days, with an ulcer over dorsum of right foot, post-surgical, post-traumatic status, with absent pulsations of right side from dorsalis pedis artery up to popliteal artery. My diagnosis is a 62-year-old male who is a known case of diabetes mellitus with peripheral arterial occlusive disease of right lower limb with dry gangrene of left foot and arterial ulcer, probably involving femoropopliteal artery, most likely due to atherosclerosis.
Okay. You say, is the disease present on both the legs, right and left as well?
Yes, sir. After my examination, I feel it is on both the
So the
sides.
dry gangrene is in the left foot.
Yes, right side, sir. The gangrene is in the right foot, sir.
Okay, so there's a bit of confusion in writing there, isn't it?
Ischemia signs are there in the left limb, but it is asymptomatic, isn't it? As per your
Yes,
discussion, your explanation,
Yes,
the
sir.
asymptomatic ischemia on the left lower limb.
Yes, sir.
Okay, go back to the picture, please. You have a clinical photograph. Yes. Right, I'm able to see that on the right side. Second, fourth, and fifth are there. There's the skin changes as well there. There is the bleb, you said. I think the bleb is ruptured already, and
Yes,
it
sir.
looks like
It was ruptured
it
at
is
home
dried
itself,
up.
sir, spontaneously.
Okay, so dorsal aspect we could see ulcer there. There is in the ulcer some areas you can see that there is some amount of granulation tissue, or is that a granulation tissue?
Sir, it was not healthy granulation tissue, sir. It was entirely covered by slough.
Okay. When I see on the plantar aspect of the foot,
Yes, sir.
is there a connection there deep to that? on the lateral aspect of the foot, forefoot, beneath this fourth
No,
and
sir.
fifth.
There was no fluctuation, sir.
Okay, and if you see in the midfoot, there is a lesion there, something looking like, pale. What was that?
Sir, on examination, sir, it was normal skin only, sir.
Okay.
What was that? Is it post-traumatic? Do you think it is post-traumatic? Yes. That lesion
Could
on the
be, sir.
dorsum.
Sir,
Okay.
on the dorsum, it is post-traumatic only, sir.
Go back to your
Post-traumatic.
diagnosis. Okay. Okay, Gajal, go back to diagnosis. The slide of diagnosis. Okay. So what are the points favoring your diagnosis?
Sir,
What are the points?
so, starting with the age of the patient itself, sir. He's an elderly male
Right.
who is a chronic smoker and
Right.
alcohol consumption.
Why? How
long,
alcoholism is important? How history of alcoholism is important in this patient?
sir, sir, alcohol also releases free radicals, sir. And
No, alcohol per se is not related to peripheral arterial disease. So don't focus too much on alcohol history in this
yes,
case.
sir. Yes.
Okay, so speak to only history of smoking. Ignore alcohol.
Yes, sir.
As far as disease is concerned, ignore alcohol. Alcohol can give it to some other diseases, but
Yes,
not really in relation to this disease. Okay, chronic smoker. Then
known case of diabetes mellitus, which is long-standing.
right.
Then
What is the incidence of peripheral arterial disease in non-diabetic patients? What is the
Sir?
relationship? What is the relationship of peripheral arterial disease in relation to diabetes mellitus?
Sir, a person who has diabetes mellitus, for him, the odds ratio of getting peripheral vascular disease is 2.7, sir.
Right. So, along with the age of the patient and also duration of the diabetes,
Yes,
the
sir.
chances or incidence of peripheral arterial disease is higher. It is directly proportional to not only with the age of the patient, also the duration of diabetes mellitus, isn't it?
Yes, sir.
Right. What the point to say dry gangrene?
Sir,
please.
dry. Yes. So dry gangrene because first appearance of the gangrenous area, which is dry, shriveled and mummified. There is presence of line of demarcation. It is not associated with any swelling, any discharges, and it is not foul smelling.
Okay, what does the line of demarcation indicates?
Sir, it is the area between viable and non-viable tissue, sir.
Okay. Will that be there in case of wet gangrene?
No, sir.
There is no well-defined line of demarcation in wet gangrene. There's something called as separation by sepsis, separation by asepsis.
Asepsis.
The aseptic separation will be there of viable and non-viable tissue in case of dry gangrene.
Yes.
There will not be any skip lesions. Skip lesions are the features in case of wet gangrene.
Wet gangrene.
Maybe because of spread of infective thrombi, isn't it?
Yes.
Right. What is the level of occlusion here? You mentioned.
Sir, according to my examination, sir, femoropopliteal occlusion, sir.
Okay. Dr. Gazal, even
Yes,
if there is an occlusion in the femoral artery, is patent, isn't it? Femoral artery is felt?
Yes, sir. Feeble it is, sir, over right side.
It is feeble. Well, you're
Yes,
justifying your finding. If the common femoral artery is present, it's unlikely that the leg will thigh will be cold. What is the main arterial supply of the thigh muscles?
Femoral artery, sir. Superficial
Which
and
femoral?
superficial femoral arteries.
Okay, so it is usually the profunda femoris artery which supplies the major muscle, all the muscles of the thigh. Superficial femoral artery only acts as a conduit to take blood from the femoral artery to the legs.
Yes.
So if there is a femoral which is patent, it's unlikely that the leg will be cold in the thigh region. Okay, that's point number
Yes, sir.
one. Point number two, that findings are looking like there is an element of wet gangrene as well. Not sure how many of you would agree on the plantar aspect, and also there is a skip lesion, and in the midfoot I see that there is a lesion there. That could be a wet gangrene and an infection in the plantar aspect of the foot. If you keenly see, there seems to be a small line communicating from the forefoot lesion between the second and third, fourth and fifth toes and the midfoot lesion. It could be still a septic wet gangrene. Okay, let us see what further we have.
Yes, sir.
Okay, proceed
Yes,
further
sir.
if there are no. So femoropopliteal disease is what you're looking at. What about the other leg? Is there a PAD there also? You said there is a peripheral arterial disease, isn't it?
Yes, sir.
Okay.
Sir, over the left lower limb, dorsalis pedis, anterior tibial and posterior tibial are not palpable.
Correct.
Popliteal and femoral pulsations were feeble, sir.
Popliteal is also feeble?
Yes, sir. I felt it to be feeble, sir.
Okay.
And one more thing, Gazal. I think in
Yes,
history you have mentioned that there is one significant negative, that is there is no history of importance, isn't it? Can you
Yes,
go
sir.
back to history slide? History slide.
Yes, sir.
Somewhere you have
Yes, sir.
mentioned it. Why you want to mention that history of importance? Though it is not
Sir,
very
yes, sir. Sir, impotency forms a component of Lerich syndrome, sir.
What is that
Which,
syndrome?
sir, there is gluteal claudication, absent femoral pulsations, and impotency in that syndrome.
Is it
Basically,
involvement
there
of
is,
femoral artery? Will there be involvement of femoral arteries or some more proximal?
sir, occlusion will be at the level of iliac artery, sir.
Yeah, common
Ioto-iliac
iliac
region.
artery.
Yes,
Common
sir.
iliac artery, that too bilateral,
Yes,
not
sir.
just unilateral. Bilateral
Yes, sir.
common iliac artery involvement should be there, isn't it?
Yes,
So
sir.
in this case, patient, what is the age of the patient?
62 years, sir.
Old age patient. Impotence is quite possible even in normal individuals without
Yes.
PVD, without that also, isn't it?
Yes,
Second
sir.
is diabetic patient. He is a non-diabetic, isn't
Yes, sir.
it? Diabetic patients are prone for impotence again. It is one of the
Yes.
first sign of autonomic neuropathy, you know.
Yes, sir.
First sign of autonomic neuropathy in diabetic patients is impotence itself,
Yes.
isn't it? So you should know about this impotence in this patient in the case of peripheral vascular disease.
Yes, sir.
Another standard question will be, Gazal, is do you
Yes,
think
sir.
it is atherosclerotic or this could be a Bursar disease also?
Sir,
Can it be Bursar disease?
no, sir, I don't think so.
Yes, tell me,
Because,
justify.
yes, sir. First of all, his age, sir. He's
Huh.
elderly made Burgess disease. Usually we encounter between 20 to 40 years of age, sir, in males.
What presentation or onset?
Onset, sir.
The onset of the disease should be before 40 years. Okay.
Yes, sir. Then presence of diabetes mellitus pushes the diagnosis more towards atherosclerosis.
No. Yes, you are right. If there is diabetes, the diagnosis of Bursar disease is ruled out.
Yes.
Okay, good, correct.
Which type of arteries are involved in Bursar disease, Gazal?
Sir, small and medium sized vessels, sir.
Atherosclerosis,
Large
preferably
size.
it involves medium to large size vessels, isn't it?
Yes. Yes.
So now,
Okay.
Gazal, I have a question.
Yes,
Can
sir.
you still have a gangrene, dry gangrene like this if you have a dorsalis pedis palpable in diabetics? Can you still have this two digital gangrene despite
Yes,
of having a palpable posterior tibial and anterior tibial or dorsalis pedis for that matter?
Sir, if patient, if there is a acute presentation, sir, with presence of embolus.
No. You're moving away. Well, there is one possibility that if there is a microembolism. Second thing is there could be a microvascular disease as well, which gets precipitated by the trauma or minor injury, and then it can result into a dry gangrene.
Yes.
Okay, right. Next, whatever.
Okay, how will you proceed with this patient, Gajal?
Yes, sir. Sir, we have to follow a holistic approach, sir, for his management, including laboratory tests, imaging, and he also needs cardiac evaluation like ECG and echocardiogram and pulmonary evaluation. Moving on to his investigations, his hemoglobin was 12.7 grams per deciliter. Total count was raised, sir, 24,840. His RBS.
What it indicates?
So there is active infection, sir.
There is a focus of infection, isn't it?
Yes, sir.
So this investigation makes you to suspect possibility of even wet gangrene also.
Yes, sir.
As well as rightly pointed out, there is
Yes,
some
sir.
finding on examination, isn't it?
Yes,
Though
sir.
there is absence of pain, though there is no tenderness, though there is no local rise of temperature because of ischemia, again the signs
Yes.
will be masked.
Yes, sir.
Then there may be hidden sepsis. You cannot rule out a component of wet gangrene.
Yes, sir.
And the infection may be there because of previous history of trauma.
Yes, sir.
Isn't it? We cannot rule out.
Yes.
Okay. Okay. Proceed.
His
Now,
random blood
why
sugar.
would you want to do a serum creatinine?
Sir, to check for his kidney function, sir. In
Okay.
the next steps, we may choose to opt for CT or MRI angiography, sir, which uses contrast, and for that, to assess the renal function, we get the serum creatinine done, sir.
Also, they're at risk of diabetic nephropathy. That's one.
Yes, sir.
You would want to detect that as well.
Yes, sir.
Contrast is one. And
Yes,
if you
sir.
want to do any endovascular interventions in this patient, you will be using lots of contrast. So it's always better
Yes, sir.
to look for a creatinine. All right, proceed.
Because of underlying sepsis, because total count is very high, isn't it?
Yes, sir.
Again, patient may be in case stage of acute renal failure or AKD. There is
Yes, sir.
possibility, isn't
And
it?
your patient is
For
already on
these reasons,
metformin.
Yes, sir.
Metformin.
Yes, sir.
Okay. That is another thing you should keep in your mind.
Yes. Lipid profile, total cholesterol is 145, serum triglyceride is raised 285, VLDL is also raised 57, HDL is low 20, LDL is 68, cholesterol to HDL ratio is 7.25.
So
Moving
there
on
is an
to,
element of dyslipidemia.
yes, sir. Yes, sir.
Yes. Okay.
Moving on to arterial Doppler of right lower limb. There is reduced caliber and flow velocities with biphasic flow in left common femoral, superficial femoral, profunda femoris, popliteal, anterior tibial, posterior tibial arteries, and dorsalis pedis artery. There is a non-calcified plaque in femoral artery in mid-thigh measuring 16/2 mm, causing stenosis of less than 25%. Another non-calcified plaque causing complete stenosis of lower femoral artery at the adductor canal, and gangrenous changes noted in fourth and fifth toe.
Wait. Hold on. What is this biphasic flow?
Sir,
There's a bit of confusion here. The gangrene is present in which leg?
sir, right, sir.
And your Doppler was done in right. And you mentioned that, see, lots of errors are there in your typing there. Biphasic flow noted in the left common femoral, left superficial femoral, profunda, and all the way down into the anterior tibial and posterior tibial. It is biphasic, is it?
Yes, sir.
So let's say it is right. We'll correct it like that. Then what is this biphasic and what are the phases of flow?
Sir, there are normally three phases of in a normal arterial flow, sir.
Okay.
The first one is systolic. Second one is reverse early diastolic. And the third one is late diastolic, sir.
Right. Okay. Good. Excellent. You know about it. Let's keep there. There is a femoral artery mid-thigh adductor canal, 25%, less than 25% stenosis.
Yes, sir.
Okay. Is it significant?
Sir, more than 50 is usually significant.
And peripheral arteries is more than 75%, that is considered as significant. It varies in different places, like carotids, it is slightly different, but you should take anything more than 75% should be a significant one and think of intervention. Okay, right?
Yes, sir.
Mid-thigh. Okay. So there is another stenosis that is totally occluding, is it?
Yes, sir.
Adductor canal. Okay. Adductor canal is what we would look at as mid-thigh. Okay. All right. So 100% occlusion. It's
Yes.
difficult to explain this biphasic flow in the anterior tibial arteries and posterior tibial arteries when you have 100% complete stenosis. Not sure about it. Ultrasound is always observer dependent. So let's skip and see what else do you have.
Sir, CT angiograms of lower limbs was done.
Hmm.
It shows extensive atherosclerotic changes in form of vessel wall calcification and thickening in aorta and its branches, predominantly in intrarenal aorta with 50% luminal stenosis. There was a moderate ostial narrowing of left renal artery. In the right lower limb, there was atherosclerotic changes in arteries of right lower limb in the form of vessel wall calcification, causing irregular, mild to moderately narrowed lumen. Focal short segment of with complete thrombosis of mid 1/3 part of superficial femoral artery with distal arterial reformation through collaterals. Popliteal artery is normal in caliber. Anterior tibial artery and peroneal arteries are mildly narrowed in caliber, and there is extensive calcification along posterior tibial artery causing severe luminal narrowing. For the left lower limb, atherosclerotic changes in arteries of left lower limb in form of vessel wall calcification causing irregular mild to moderate narrowed lumen. Focal short segment complete thrombosis of mid 1/3 part of superficial femoral artery in left lower limb as well, with distal arterial reformation through collaterals. Popliteal artery is normal in caliber. Anterior tibial and posterior tibial arteries are mildly narrowed in caliber.
Okay, so more or less the picture is looking similar on either side, isn't it?
Yes, sir.
So why does he have symptoms on the right foot and not on the left?
Sir, in the right side, the report gives that there is severe luminal narrowing in the posterior tibial artery, sir.
Okay, right. So when the lesions are multiple, and it also depends on the distal vessels as well. Okay, that may good explanation. Proceed. Next.
So moving on to
Right.
manage. Yes.
So okay. Right. So how are these distal vessels perfused despite of occlusion, 100% occlusion there?
Sir, because of the formation of collateral, sir, there is distal runoff which can be seen in this angiogram.
If the blood flow is getting into the distal vessels, is there any need for intervention here? Should we be doing anything?
Yes, sir.
The blood
Since it
seems to
is
be going
progressive disease, sir, the plaques will keep on increasing since atherosclerosis is a systemic
correct.
disease. There may come a point where the collaterals might also stop working, sir.
Okay. Let's stop there. Let me give you a clue. It is just because whatever number of collaterals come, they can never match a flow of a native artery. It is just showing a filling there in the CT imaging, but no matter
Yes,
whatever amount of blood comes from collaterals, up to even they say even there are 1,000 collaterals, they may not match the flow of the lumen, what is the natural flow. Also,
Yes.
if you see in the aorta there, aorta also there is a significant narrowing. I mean, it's probably around 50%. Can you appreciate that?
Yes,
Okay.
sir.
All right, good. In the best interest of time, we will proceed. Tell us what is the treatment. It's already 9:50.
What
Yes,
are the
sir.
types of angiography? Gazal, can you tell
Sir,
the types of angiography?
Sir, CT angiography or and MR angiography, sir.
Okay, they are advanced. Any conventional
Digital
type?
subtraction angiography, sir.
Okay, right. What do you mean by conventional angiography? It is the basic for all the other types of angiographies. Conventional angiography is retrograde femoral angiography done by Eldinger method.
Yes,
And
sir.
you should not forget that. Then comes
Transfemoral.
advances. Yes,
sir.
then come the recent advancements like CT angio, MR angio, digital subtraction angiography,
Yes, sir.
all those things, isn't it? So what is your plan of treatment in this patient?
Sir, first of all, I would like to start with lifestyle modification, sir. Patient has to stop smoking immediately. Then there may also be patients where Burgess positions and Burgess exercise may help. Heel raise exercise may help. We have to prevent minor trauma, and weight reduction should also be done. Then risk
See,
reduction is.
this patient has already come to you with dry gangrene.
Yes, sir.
Do you think all this lifestyle modification will help to
No,
reverse
sir.
that dry gangrene?
Not in this patient, sir.
Huh?
Not in this patient, sir.
Yeah. So you have to start your management with the whatever presentation is there, whatever is your diagnosis, isn't it?
Yes, sir.
You have to manage the patient. Then you can give prophylactically advise that lifestyle modification so that you can prevent the recurrence, or you can
Yes,
prevent
sir.
the similar disease on the opposite limb, contralateral
Yes,
limb,
sir.
isn't it?
Yes.
So what can be done to that dry gangrene?
Yes, sir.
What can be done to that dry gangrene? Is it a reversible condition or not?
No, sir. It's an irreversible condition, sir. So for now, we can go ahead with conservative amputation, sir.
Which is the type of gangrene which can be prevented or which can be reversed back? I mean, it is not a fully developed gangrene. Some prefix
Yes,
is written to them prior to that. Some prefix is written. Pre-gangrene.
Yes, sir.
What do you mean by pre-gangrene?
Sir, pre-gangrene are those changes noticed in the body wherein which suggests that the blood supply is so precarious or inadequate that it may lead to tissue death. Signs
Not
of
many other parts of the body,
pre-gangrene.
mainly in the limbs, isn't it?
Yes, sir.
Distal extremities.
Yes,
So what are the components that pre-gangrene?
sir. Presence of rest pain, sir, edema,
Good.
then hyperesthesia and ulceration, with or without ulceration.
Yeah. If you are able to see any patients in a pre-gangrene stage, it is very well preventable, provided you do relevant investigation and you can manage, isn't
Yes,
it? But in this case, there is well-developed dry gangrene,
yes, sir.
which is irreversible,
Yes, sir.
isn't it? How to manage that?
Sir, amputate. I would like to go ahead with raise amputation of the gangrenous toes, sir.
Do you think they will heal? Already you have done CT angio.
Sir, for the occlusion at the mid-thigh level, sir, at the femoral-popliteal junction, we can go ahead with revascularization procedure, sir, in the form of transluminal angioplasty or femoro-popliteal bypass.
So for that endovascular management or vascular management, I think Sunil sir is the better person to discuss.
Yes, I'll speak about it. I have some objections for the drugs that she is using.
Yes, sir.
I have a strict thing about anesthetics in the form of anesthetics. They are never used in patients who are diabetic and peripheral artery disease or cardiac for that matter, especially in diabetics. We would want to avoid diclofenac or aceclofenac. Our drugs of choice would be opioid along with a paracetamol, and use some opioid patches if required.
Yes, sir.
And I see that, Ghazal, you are not bothered about any antibiotics at all here. What is the first thing? What is the first thing that will result into an amputation? Is it a spreading infection or the vascular disease?
So the spreading
Which is more
infection,
important?
sir.
Spreading infection is much more dangerous. That
Yes,
needs
sir.
to be attended to first.
Yes, sir.
And probably you will have to start antibiotics.
Yes, sir.
Also, do some damage control surgery in which you make some incisions there and try to see if there's a collection, which I am highly suspicious of based on clinical finding and also your counts.
Yes, sir.
Okay, I would like to see if there's any collection there which can be utilized for culture and sensitivity, and also by draining it, it will prevent further progression. So I'm concerned about wet gangrene component of it here.
Yes, sir.
All right, you agree?
Yes, sir.
So antibiotics should find a place.
Yes, sir.
And then damage control surgery, and then revascularization,
Yes, sir.
and then wait for your re-amputation, other things to happen. That should be the sequence here.
Yes, sir.
First important is wound management, get rid of infection.
Yes, sir.
Okay, so that is one thing there, antibiotics and debridement. And next will be now percutaneous transluminal angioplasty and stenting, right? So you use a conventional angiography, as sir mentioned already, going through one of the femoral arteries and crossing over and reaching the ipsilateral limb, and then doing a
Yes.
diagnostic angiography. And if it is a mid SFA occlusion, that is at the adductor canal, you can also go ipsilateral femoral artery by antegrade puncture. It's a bit confusion of terms for you probably. Antegrade, because sir mentioned that I should talk about it, I'm telling you, retrograde and antegrade. On this,
Yes.
you can come from the opposite femoral artery, which is called as retrograde, because you are going against the flow.
Yes,
What
sir.
you can do is you can also enter through the right femoral artery, which will be called as antegrade because it is going along the flow.
Yes, sir.
Either ways you can do it.
Yes, sir.
I think there is some
We are
network issue
lost.
with
We lost
yeah.
some network issues. Meanwhile, Dr. Sangmesh, Dr. Mamta, vascular surgeon, is also here. She can give us some points. And welcome Dr. Tejaswini Vallabha also. She is also there in the. Good evening, Dr. Tejaswini and Dr. Mamta. Hello. Hello.
Hello.
Yeah, Dr. Tejas.
Hello.
Dr. Mamta. Yeah, Dr.
We are back, I guess.
Yeah,
I
please
don't know if it is
complete
Sangmesh or
meanwhile.
Anandravi who is.
Yeah.
So Anandravi or Sangmesh has stopped it because we are going continuously without non-stop like this.
No, sir. We are just about to interrupt, and there we got another 2 more minutes to wind up this case, sir.
Yes.
So I think that should be the plan sequence of planning, which I said already, Dr. Gazal, and transluminal angioplasty and probably it's a femoropopliteal bypass also can be done depending on, because the patient is availability to the vein and other things. Usually we use the reversed saphenous vein graft for a bypass below the inguinal ligament. So those are the two revascularization options. So yes, definitive amputation. No. And then probably we can debride and remove the toes if they're already gangrenous and whatever reverse, and reconstruct that wound, and then continue them on all the medications for atherosclerosis, the clopidogrel or the statins that you're using. So that should be the treatment. Yeah.
It's something like a comprehensive management, Gazal.
Yes, sir.
Because there is also diabetic patient, you have to manage diabetes simultaneously.
Yes,
you know the different components of diabetic food management, isn't it?
Yes, sir.
There's something called as microbiological control by giving antibiotics. There is something called as wound control by taking care of the wound. There is something called as metabolic control, that is the control of the diabetes, control of hyperlipidemia, whatever it is there. Then there is something called as mechanical control, offloading if there is any diabetic foot ulcer, especially on the plantar aspect, and vascular control, what sir has discussed.
Yes, sir.
All these comes under comprehensive management of diabetic foot.
Yes.
Isn't it? Then comes the lifestyle modification to prevent the recurrences, isn't it? Or to prevent the occurrence of disease on the opposite limb.
Yes, sir.
Okay. Okay.
Thank you, Dr. Gazal. Before we wind up, closing remarks by Chairman, Madam Dr.
Yeah,
Naz,
yeah.
ma'am.
Yeah. Thank you, Dr. Ghazal. It was a very good presentation. And thank you, Dr. Manjunath Kotennavar also
Thank you, madam. Thank you for
yeah,
giving us
for
the opportunity.
staying so long and completing both the cases. And Dr. Sunil for complementing this session. It was indeed a very good discussion. And I thank both the moderators and all the presenters and all the members present here. And I recognize the presence of Dr. Tejaswini and Dr. Mamta. They have just left, but I just want to say that they had also participated in the discussion. If Mamta is there, she can just give us some remarks if she's there. Dr. Mamta, I think she has left. Over to Dr. Sangmesh for a vote of thanks.
Thank you, ma'am. We thank both of our examiners, Dr. Manjunath sir and Suresh Badiger sir, and a special thank to Dr. Sunil Joshi sir, who was dropped in the last minute for this case presentation. And we would also like to thank both the postgraduates who have done a very good case presentation, and all the office bearers of the KSCASI and all the postgraduates who have stayed back for listening this case presentation. Thank you, ma'am.
Yeah.
Thank you all.
Thank you all.
Thank you,
Good
sir.
night.
Thank you. Good night to all. Thank you.
Thank you.